heart disease. The congenital heart disease divided into the two types, right? Congenital disease divided into the two types. One is cyanotic heart disease, right? Another was a acyanotic heart disease. Okay, so before discussing these diseases in detail, first we understand the types of the shunt, right? In cyanotic heart disease, shunt will be right to left, and in acyanotic heart disease, it will be left to right. So this left-sided heart contain oxygenated blood, right?
Yes.
Okay, and this right side heart contain deoxygenated blood. Deoxygenated blood means less oxygen. So normally there is a separation, septum, partition in between. There is a no mixing of this oxygenation and deoxygenated blood. So the oxygen saturation is also important. Like the oxygen saturation in superior vena cava is 75%. It's variable. Generally, we accept 60 to 80%. So 75% we spool. It's normal. So 75% in inferior vena cava and 75% in right atrium and 75% in right ventricle, right? This is
Right.
oxygen saturation and 75% oxygen saturation in the pulmonary artery, right? This
Right.
is normal. After the pulmonary artery, this blood goes to the lungs. And so lungs cause oxygenation of the blood. And this blood come into the left atrium through the pulmonary vein. And this pulmonary vein contain 99% of the oxygenated blood. So there is a change in between 99 to 95% in the left atrium. Can anybody tell why this change take place? From 99 to 95%. So this is why this change take place. Rock.
I'm not sure.
Okay, basically there is a vein like BCN veins that drain directly into the left atrium. So that's why these some veins that are directly drain into the left atrium that decrease the oxygen saturation in the left atrium somehow. So 95% in the left ventricle. So 95% is aorta. So why I'm emphasizing in on this oxygen saturation? Because this concept is a high yield, right? So
Okay.
now I'm going to discuss about different shunts. So there is two type of shunt, left to right, right to left. So right to left means this oxygenated blood mixing with
Huh?
this oxygenated blood, right? So
What?
is there any dropping in this oxygen saturation at the left side as well?
Wait, you're saying oxygenated or do you mean deoxygenated? Right to, because you're talking about right to left.
Okay, so right sided contain deoxygenated blood, right? And left side
Okay.
contain oxygenated blood. So if blood is from the right side, there is a defect in this septum. Let's suppose this is a atrial septal defect, right?
Yes.
If the blood is moving from left to right, left to right. So this is oxygenated blood. This oxygenated blood mixed with deoxygenated blood. So this deoxygenated blood, there is an increased oxygenation take place. So let's suppose this goes to 85%, right?
Okay.
Maybe
Yes.
80%. Does it make some sense?
Yes.
Okay. Let's suppose there is a defect in ventricular septal defect. So the shunt is from, because left sided has higher pressure, from left to right. The left side contains higher oxygenated blood. So this higher oxygenated blood mixed with lower oxygenated. So it will lead to the increased oxygenation in the right ventricle. So it again increase 80, maybe 85, but it's more than 75%, right?
Right.
Okay. So why this is important? Because USMLE love to ask the question on basis giving the oxygen saturation on the different chambers of the heart, and they love to ask that which pathology is that, right? Is this a atrial septal defect? It is ventricular septal defect? Is this a PDA? Is this tetralogy of Fallot? Is this Eisenmenger syndrome? Right? So first you
Yeah.
have, hello?
I think
First
that person forgot the mic on, so you can continue.
okay. It's okay. Wait a minute. It's okay, doc. It's okay. Give me a minute. I am trying because the slide is not working. Just a 1 minute. The screen is still visible or not?
No, it's not visible.
Just 1 minute. Still not visible?
No. Okay, now it's visible.
Okay. Okay. So left to right shunt and right to left shunt. So left to right shunt cause cyanosis. Left to right shunt cause a cyanotic lesion, and right to left shunt cause cyanotic lesion, because right to left shunt means this
Deoxygenated blood.
deoxygenated blood mixed with the oxygenated blood. So it will lead to the decreased saturation of this left atrium, right? So in this way, the decreased saturation of the left sided chambers take place. So can anybody tell me the name of left to right shunt diseases? VSD,
ASD.
ASD, ASD,
PDA?
Beta ductus arteriosus.
EDA.
Yeah. Those will be your left to right.
Okay, so the most common congenital heart disease is VSD,
VSD.
right?
Yes. Yes.
So the VSD is basically defect in ventricular septum.
Ventricular
Septal.
So there is
Yeah.
defect in the ventricular septum, right? So
Yes.
there is this oxygenated blood from the, sorry, this is a it VSD, ventricle septal defect. So this is a ventricle septum. So there is defect in this septum. So this higher pressure in the left ventricle mixed with right ventricle, right? So it has 95% of oxygen saturation, and right ventricle is a 75% oxygen saturation, right? So oxygenated blood mixed with deoxygenated blood, right? So it will lead to the acyanotic lesion at birth. So what will the change in oxygen saturation in the right ventricle, in ventricle septal defect?
Increase.
Sorry?
Increase oxygen saturation, increase.
Okay, so the oxygen saturation in right ventricle is increased. Increase O2 saturation in this right ventricle as well as pulmonary artery as well. Pulmonary artery as well, right? So it increased more than 75%, maybe 80, maybe 85, right? Percent. Does it make some sense to you? Rock, does it make some sense to
Yes.
you?
Yes.
So if the left side blood that contained higher oxygen
Yes.
mixed with the right side blood of the heart that contain less oxygen, so it will increase the oxygen saturation of that chamber and vessels. So USMLE loves to, they give you the clinical minute of the VSD. So VSD present as, give their VSD presentation, and they love to ask oxygen saturation in left atrium, left ventricle, right ventricle, pulmonary artery, right atrium. So in left atrium, what will be the oxygen saturation in VSD?
No
Doc,
change.
not change. It is 95%. But in left ventricle,
It will be the same.
Same.
so it will be remain same,
Yeah, not the same. Not yeah, same 95. Yeah.
right?
Yes. So basically, if I'm understanding you correctly, the concept you are portraying is that the change will only happen to the deoxygenated side, especially when if you're like from left to right, because you have oxygenated blood being added to deoxygenated blood.
Because
So
because
the
because yes,
percentage will increase.
yes, because the left side has higher pressure. So
Okay.
blood move from higher pressure to the lower pressure, right?
Right.
Okay,
Yeah.
what happened in the right ventricle? Oxygen saturation.
It's going to increase because it's
Let's
coming
suppose
from
it,
left to right.
let's suppose it 85%. Normally it is 75. What happened to the pulmonary artery? In normally pulmonary artery's oxygen saturation is 75%. But what about in case of the ventricle septal defect?
Increase.
It's
Increase. It's more than
increase.
75%. So it's maybe 80 or 85%. What happened in the right atrium?
If it's
Change. The same.
Sorry?
it will be the same.
Unchanged. Remain unchanged.
Unchanged.
So
Yes.
these kind of the things you have to prepare for the USMLE. Right?
Yes.
Okay.
Now, so just quick question. So the right atrium oxygenated blood would have only increased if it was an atrial septal, right?
Yes, we
Maybe
will
from
discuss
left.
the atrial septal changes as well. Yes, you are right. Atrial septal defect.
Okay. Okay.
Okay. So, what kind of the murmur in the ventricle septal defect? Can anybody tell me?
Holosystolic murmur.
Okay, it's mainly holosystolic murmur. Holosystolic murmur. And where it is heard?
Left sternal border.
At
Cuspid area.
okay. At lower left sternal border. Right.
Yeah.
So, can anybody tell me the pressure changes in the Eisenmenger syndrome? Eisenmenger syndrome. Eisenmenger syndrome.
Yes, it becomes somewhat paradoxical. The pressure in the right ventricle is going to increase.
Pressure in which oxygen saturation changes. I am talking about oxygen saturation changes. Oxygen saturation changes in Eisenmenger syndrome.
But I believe oxygen saturation would drop in the left ventricle.
Let's suppose the initially VSDs left to right shunt, right?
Yes.
So what happened in Eisenmenger syndrome? It becomes right to left shunt because of increased pressure in the pulmonary artery, right? So so it will lead to the pulmonary hypertension and it will lead to the right ventricle hypertrophy. So right ventricle pressure become greater than the left ventricle pressure, right?
Yes.
So the reversal of the shunt take place in this syndrome. So this contain deoxygenated blood and left ventricle contain oxygenated blood. So there is a mixing. This is right to left shunt. There is a mixing of this deoxygenated blood with this oxygenated blood. So what will you affect in the left ventricle?
There will be a decrease in oxygenated blood.
Yes, so this oxygen saturation will be decreased. Right? And what about the change in aorta, oxygen saturation in aorta?
Decrease.
Decrease, right. It will also decrease. So USMLE love to ask these kind of the stuff. They give you the long history of the ventricular septal defect and the patient is left untreated and he develops these kind of the changes and he becomes cyanotic, right? So what will be the oxygen saturation changes take place? Like, so USMLE love to ask these kind of the stuff. So what changes in Eisenmenger syndrome? Left ventricle oxygen saturation, aorta, right ventricle, left atrium, pulmonary artery, and superior vena cava. Okay. So what happened in left superior vena cava in Eisenmenger syndrome?
No change.
No change. Right? Pulmonary artery. Pulmonary artery.
No change.
No change also.
Left atrium. No change.
There should be no change.
No change.
Right ventricle, no change. The change takes place only left ventricle and aorta. I hope it makes some sense to you. Does it make some sense?
Okay. Can we just go a step further on the rationale behind the no change, and then also for the the change in the left ventricle and
Okay,
aorta?
so why there is no change? Because in the Eisenmenger syndrome, this is from right to left.
Left.
Okay, so this deoxygenated blood mixed with the left ventricular blood. So that's why the change takes place in the left ventricle. And from the left
Yes.
ventricle, blood goes to the aorta. So aorta contain that blood that is from the left ventricle. So only change takes place in the aorta and the left ventricle. The remaining chambers and vessels remain unchanged because there is no effect on that. Right?
Okay.
Okay. So moving toward the atrial septal defect. So, okay, one more thing. So, what are the, if the VSD is large, what about the murmur? It's loud?
No, it's going to be dull.
Low
It's not
intensity.
going to be dull.
Yes. Okay. So, ASD, atrial septal defect. The atrial septal defect, ASD. So, it is a defect in between this septum, right? Can anybody differentiate between atrial septal defect and patent foramen avail? Embryological differences.
الاي failure between الفيوجنز بتاعت السبتم برايمم and septum secundum.
Yes, the patent foramen avail is basically fusion defect. Fusion defect of septum primum and septum secundum. But the ASD is mainly defect in
ostium secundum.
Okay, so it's basically ostium secundum, defect in ostium secundum, right?
Yes.
So it may be due to ostium primum when it takes place other anomalies, but most commonly it is ostium secundum, right? And this atrial septal defect is associated with Down syndrome, right? Okay, so what happened in the atrial septal defect? Which kind of shunt is that? Atrial septal defect is
left to right.
Left to right shunt. So left to right shunt present with a cyanotic lesion. A cyanotic lesion, right? So this acyanotic lesion, this left atrium contains oxygenated blood, 95% oxygen saturation, and this right atrium contains 75% oxygen saturation. Okay, so if this oxygenated blood mixed with this deoxygenated blood, what will change take place in the right atrium? It will increase the oxygen saturation in the right atrium. From the right atrium, blood goes to the right ventricle. So it will also increase the oxygen saturation in the right ventricle. It also increase the oxygen saturation in the pulmonary artery, right? So
Yes.
these three changes take place in the atrial septal defect. And again, USMLE love to ask these kind of stuff. Okay. So the most high yield stuff, what kind of splitting takes place in ASD?
What type of what takes place?
It is fixed splitting.
Oh, fixed splitting. Yes.
It means that fixed splitting of S2 sound. It is independent of respiration.
Spiration.
Right?
Yes.
Independent of the respiration. Right? So the
Yes.
high yield step regarding the ASD is the fixed plating of S2 and the chamber changes, right? So oxygen
Yes.
saturation changes that takes place in the atrial septal defect and the embryological cause, because what is the ostium secundum defect is the most common cause of the atrial septal defect, and if it is due to the ostium secundum, or sorry, ostium primum, it is associated with other cardiac anomalies, and it is associated with
Down syndrome.
Down syndrome and increased oxygen saturation in right atrium, right ventricle, and pulmonary artery. Right?
Right.
Atrial septal defect may lead to
Paradoxical embolism.
yes, paradoxical.
Ambulance.
Okay, one more thing. What kind of the murmur is atrial septal defect? Murmur. Systolic ejection murmur.
It's a murmur.
Systolic ejection.
Systolic ejection murmur. So the oxygen saturation changes. Oxygen saturation changes. Oxygen saturation changes and different chambers and vessels are high yield. Right? Our next pathology is PDA. Patent ductus arteriosus. So ductus arteriosus functions. Ductus arteriosus functions before birth and after birth. Can anybody tell me before birth and after birth? Which kind of shunt?
Well, before birth is going to be right to left.
Yes, before birth it is right to left shunt. And after birth is left to right shunt. Right? So it is a communication, ductus arteriosus. It is a communication between pulmonary artery and aorta. Pulmonary artery and aorta. Right? So this is communication, ductus arteriosus, pulmonary artery and aorta. So what happened after birth? Normally, what happened after the birth? There is a decreased pulmonary vascular resistance.
Right.
So at birth, what happened? Decreased pulmonary vascular resistance. This leads to left to
pressure in pulmonary artery.
Right, so left to right shunt. Is there any association with prostaglandin? And there will be the decreased prostaglandin as well.
Yes.
Right?
Yes.
So these changes associated with birth, and it will lead to the closure of this ductus arteriosus. That is a connection between pulmonary artery
and the aorta.
So two changes: decreased pulmonary vascular resistance and decreased prostaglandin. So it will lead to the closure of ductus arteriosus. So if you want to patent ductus arteriosus, what drug you use? Can anybody tell me?
Prostaglandin.
Prostaglandin. So prostaglandin. Yes. Okay. So can anybody tell me the changes, oxygen saturation changes in the PDA?
If you do what with the PDA, you broke up. Can you repeat?
Okay. Patent ductus arteriosus. In patent ductus arteriosus, what oxygen saturation changes take place in the vessels and heart chambers? Oxygen saturation changes.
I think there should be an increase.
Increase in which?
Because now the blood is now going to the lungs after birth due to the decrease.
So try to understand. The PDA is left to right shunt, right?
Yes.
Will be
so blood is moving from aorta to the pulmonary artery. So aorta contain 95% oxygen saturation, and pulmonary artery contains 75%. So this oxygenated blood mixed with pulmonary artery. So it will lead to the increased oxygen saturation in pulmonary artery. The only oxygen saturation change that takes place in patent ductus arteriosus is increased oxygen saturation in pulmonary artery, right?
Okay.
Okay. So what is the remnant of the ductus arteriosus? What is the remnant of the
ligamentum arteriosum?
Ligamentum arteriosum, right? So this is a remnant of patent ductus arteriosus, ligamentum arteriosum. So oxygen saturation changes are again high yield. And what kind of murmur in patent ductus arteriosus? Murmur.
Machine like.
Okay, so it's a machinery like murmur. It may be, sometime it may be continuous murmur, pansystolic, right?
Yeah.
And it is associated, patent ductus arteriosus is associated with which infection? Very, very high yield. Very, very high yield stuff.
Rubella.
Rubella. So the rubella infection itself is a high yield, but its association with patent ductus arteriosus is again very, very high yield. Rubella. Okay, one more thing. If a child present with the cyanosis, and you give them oxygen, his cyanosis is improved. What will you understand from this experiment? What would be the etiology? It's a cardiac etiology or it's pulmonary etiology?
Pulmonary cause.
Okay, so it is a pulmonary, right? Cyanosis at birth. If you give them oxygen, O2 supplementation, and it is improved. So it means it is a pulmonary pathology, right? So this is a pulmonary pathology. So if the child present with a cyanosis, another scenario, cyanosis, you give them oxygen, his cyanosis not improved, right? And you give them prostaglandin, his cyanosis is improved. It means there will be a cardiac cause behind this cyanosis. So PDA sometimes is necessary. For the survival of the fetus in some congenital heart diseases. We have we have to keep patent the ductus arteriosus for the survival of that newborn, right?
Right.
I'm repeating the concept of the oxygen saturation in the patent ductus arteriosus. So the patent ductus arteriosus, what happened in PDA? So the PDA, what happened in PDA? So there is a communication that is between the pulmonary artery and aorta, right? So after
Yes.
birth, the left-sided pressure is higher. Left-sided pressure more than right side, right? So there is a shunt between left to right. So left side contains higher oxygenated blood and right side contains lower oxygenated blood. So what happened in the PDA? So this oxygenated blood is mixed with this lower oxygenated blood. So it will lead to increase oxygen saturation in pulmonary artery, right?
Yes.
So this is oxygen saturation change in pulmonary artery takes place, right?
Yes.
Okay. Now I'm moving toward to the right to left shunt. So the right to left shunt diseases are present at cyanosis. Right to left shunt, right? So these diseases present with cyanosis. Okay. So first we discuss about the disease that is known as a truncus arteriosus, right? The truncus arteriosus is basically failure to divide. This truncus arteriosus failure to divide into pulmonary
Vertebropulmonary
pulmonary artery and aorta,
aorta.
right? And aorta. So in exam, they ask about the embryological and where is the pathology lies. So there is a failure of the atypopulmonary septum formation. Failure of so truncus arteriosus is due to failure of atypopulmonary septum formation. Failure of aorticopulmonary septum formation. Okay, so this is mostly accompanied by with VSD, ventricular septal defect. Okay, so next is transposition of great vessels. So the transposition of the great vessels, which are great vessels in the heart? Can anybody tell? Transposition of
Yeah,
great
aorta and
vessels.
pulmonary trunk.
Aorta and
Pulmonary trunk.
so aorta comes from left ventricle
Left ventricle.
normally,
Yes.
and right ventricle comes from
No,
pulmonary artery
pulmonary
comes
comes from right ventricle.
from right ventricle. But in transposition, what happened?
Yeah, aorta
Left
comes from right
ventricle,
ventricle.
left ventricle give rise to
Pulmonary trunk.
pulmonary trunk, and right ventricle give rise to
Aorta.
aorta, right?
Yes.
Okay. So this is basically what is the embryological pathology that lead to the transposition of great vessels. It is due to
Failure of the spiral.
failure of the
Spiral.
spiraling. The spiraling is a high yield stuff. They are asking about what is failure. So spiraling, right?
Yes.
So the failure of spiral of the atrial septum to, right?
Yes.
Okay. So what finding you expect on the chest X-ray on the transposition of the great vessel? On chest.
Cardiomechally.
Sorry?
Cardiomechally.
Okay, I'm talking about a specific finding. Egg on string appearance. Egg on string appearance. Egg
Yeah.
on string appearance.
On string appearance. Okay.
On chest X-ray. Right?
Yes.
Okay. So if you are left untreated, so the patient, the infant may die in the first few months, right? So there is
Right.
immediate surgical intervention needed in the transposition of the great vessel. So the high yield is in the transposition of great vessel, failure of atricopulmonary septum to spiral. What about the high yield in the truncus arteriosus? Failure of the atricopulmonary septum formation. So which thing is necessary for the atricopulmonary septum formation? This is again high yield concept.
Neural crest migrations.
Neural crest cell migration is important for formation of the atricopulmonary septum. So sometimes they ask about the neural crest cell migration failure lead to these kind of congenital heart disease. Okay, the next pathology is tricus atrachia. So tricus atrachia means there is a tetratic tricus valve. Tetratic tricus valve. So it will lead to mainly two things. Right, it's lead to the hypertrophy of right atrium and hypoplastic
Right ventricle.
right ventricle. On what changes you find on ECG? ECG finding in tricus atrachia.
There will be delta wave. You find
Tal P wave
wolf
and axis deviation. So left axis deviation. So sometimes they give you the Tal P wave ECG and you have to Tal P wave ECG. That is a comparatively to the QRS complex. Sometimes it is equal to the QRS complex. Tal P wave, right?
Tal T wave.
Tal P wave. Tal P wave. This one. Tal P wave. So next one is again the most high yield pathology in the right to left shunt. Most high yield is tetralogy of the Fallot. So can anybody tell me the component of the tetralogy of Fallot? First component is
Yeah, you have pulmonary
Right
stenosis,
ventricular outflow tract
pulmonary stenosis,
stenosis,
and
and you
it is
have
the most high yield because
yes,
it determines the prognosis of the disease. Determinant of determine the prognosis, right?
yeah,
Determine the prognosis. Next one is VSD.
right ventricular hypertrophy.
Okay, VSD, right? Right ventricular hypertrophy, and fourth one is
overriding aorta.
overriding aorta. What is the meaning of overriding aorta? So let's suppose that This is a ventricular septal defect. Let's suppose that. So aorta is present at front of this VSD. So aorta present at this area, right? Aorta is not present at normal position. It's present at the ventricular septal defect. So what happens when the right ventricle contract and left ventricle contract? So this aorta takes blood from the right ventricle as well as from the left ventricle, right? Walk, does it make some
Can
sense?
you no, it doesn't. Please repeat. The way you said it, it was mixed up. Can you go over it, please?
Okay, so let's suppose this is ventricle septal defect.
Yes.
So aorta in overriding aorta, what is the meaning of overriding aorta? Aorta is placed in front of aorta is placed at the ventricle septal defect. So in yellow color, I'm showing this is aorta, right?
Okay.
Yellow color shows aorta. So when the right ventricle contracts, aorta takes blood from the right ventricle as well as from the left ventricle, right?
Correct. Yes.
So the most determine the prognosis of this pathology is the pulmonic stenosis. So this pulmonic stenosis lead to the right ventricular hypertrophy, right?
Correct. Yes.
Okay. So how the child present in the tetralogy of Fallot? Can anybody tell me? Child presentation.
Yeah. So the child will.
Child with present with hypercyanotic spell or tet spell, right?
Yes.
So what are the triggers of the tet spell? Can anybody tell me the tet spell or hypercyanotic spell triggers?
Breastfeeding.
Yes, feeding,
un-
crying.
Yes.
So these are the high yield, you know that triggers and fever because they increase the oxygen demand, and in this way they worsen the cyanotic condition, tet spells. And which thing relieves these hypercyanotic spells or tet spells? This tet spell is relieved by which thing?
Squatting.
Sorry, what are you saying?
Squatting. Like when the
Squatting.
child squats. Yeah.
Yes, squatting. The squatting, what does squatting do?
Yes. So when it
pressure.
It increases systemic vascular resistance,
resistance.
right?
Yes.
So this systemic vascular resistance increase leads to decrease right to
the shunt.
left shunt, right?
Yes.
And it will lead to the improvement in cyanosis. So systemic vascular resistance means there is increased pressure in the aorta. Let's suppose this is aorta. So there is increased pressure in the aorta. So this will cause a change that lead to decrease in right to left shunt. Okay. So what are the strong association, any syndrome association that is associated with tetralogy of Fallot?
DiGeorge syndrome.
DiGeorge syndrome. Yes. So DiGeorge syndrome, there is what can anybody tell me the DiGeorge syndrome? What is the DiGeorge syndrome?
Thymic hypoplasia.
Yes, thymus hypoplasia. So DiGeorge syndrome is again a high yield stuff, right? Okay. Can anybody tell me what oxygen saturation changes you will expect in tetralogy of Fallot?
oxygen saturation will decrease in right ventricle.
Oxygen saturation
Oh.
decrease in?
Will decrease in left ventricle.
Okay. Yes, it will decrease in
Left ventricle.
left ventricle because it is right to
Pumping to
left
left.
shunt. So it will
To
lead
left
to
shunt.
decrease oxygen saturation in left ventricle. So did you know any other pathology, any other syndrome that will decrease oxygen saturation in left ventricle? We already discussed.
Yeah, if you have atrial septal defect from right to
Menger
left.
syndrome.
Sorry?
The Menger syndrome.
Yes, it's Eisenmenger syndrome. Okay, so how will you differentiate from the Eisenmenger syndrome and Tetralogy of Fallot?
Early and late
No.
cyanosis.
It's a matter. It happens with time because at first it will be from
Yes,
left to
it
right.
happens
then it will
with the
change.
time. So it's happened
Yes.
with the time. Eisenmenger syndrome happens with the time. And in Tetralogy of Fallot, it improves with
Like with squatting can improve.
okay, it improves with
Also,
sweating. Right?
yes.
And it is worsened with
Like what exercise can worsen it.
exercise,
Yeah.
crying, feeding, this kind of the
Yes.
stuff. Okay. What is a TAPVR? These are total anomalous pulmonary venous return. So this is a simple stuff that is what happens to the pulmonary veins. These pulmonary veins drain into
right atrium.
right atrium, right?
Yes. Yes.
Okay. So, okay, one more thing. Sometimes they ask a question. A child present with acyanotic at birth. Acyanotic at birth. Right? Acyanotic at birth. So after 1 week, after few days, the child develops cyanosis. What is the mechanism behind this cyanosis?
Closure of beta ductus arteriosus.
Yes, the closure of the ductus arteriosus. Sometimes this closure takes few days. So that's why this is again a high yield, right?
Okay, yes.
Okay. So sometimes this PDA is important for the survival of the fetus. These are conditions like it is important for transposition of great vessel. PDA is necessary for transposition of the great vessel. Sometimes it is necessary for other cyanotic congenital heart diseases like truncus arteriosus. Okay, but what kind of the chest X-ray finding you expect in Tetralogy of Fallot? Chest X-ray finding.
That will be the boot shape of the heart.
Yes, this is again a high yield stuff. Boot shape heart on chest X-ray.